Okay, Assalamu alaikum. I can't see myself. It's so amazing to be here. Let me make sure I'm on the right screen. I want to welcome you all, and I'm going to do a little bit of two things. One is I see one of my co-authors is in this session. So Dana, welcome, and feel free to make any comments that you would like to, because this is your work as well. I want to talk about a couple of things, though, before we go into the actual data. And part of this is this idea of education and science under occupation. So some of you may notice that half of my presenters, half of my co-authors are not here in the United States, and I am not in Palestine. And there's a reason for that, unfortunately, in terms of what science and what education look like under occupation. And this will paint a little bit of the picture also of what COVID-19 looked like under occupation, because it is a very unique sort of set of circumstances. So as mentioned, I am a professor in the clinical psychology program at Najah at National University of Palestine. We are the only Masters of Clinical Psychology program in the West Bank. And unfortunately, as the only PhD level clinical psychologist who's licensed as a doctoral level clinical psychologist, I also am not able to be there. So I was living and working and creating this program for more than 6 years, and then was removed by the occupying forces, not once, but twice. And I do want to talk about, there is a new legislation that we are very concerned about, and we are asking our fellow universities to really be on top of. And this is a new action by the occupying forces around education. So under the new under these new legislation in the area of Samaria, which is the West Bank, we have been told that, and I want you to imagine being a university, right? So it is now no longer legal for anybody under a PhD level to come to the West Bank to teach. So all of our bachelor's level folks who would come to assist with high schools, who would come to assist with specialized programs, and our master's level folks who were teaching specialized programs in our side of our universities are no longer going to be allowed to enter into the West Bank to teach. You will not be allowed to teach for more than 2 years. If you can imagine building a career, building an academic career, being forced to leave the country after 2 years and never teaching more than 5 years in a lifetime, which means I would never be able to go back to my students. The way that we're managing this now is through virtual teaching. It is through, a lot of difficulty to get back for 30 days so that I can do some of the classes that need to be done. But we really would ask, and if you look under Birzeit University, there is an amazing statement that we're asking universities here in the United States and internationally to support. Because again, if we are interested in Muslim mental health, we have to have viable Muslim mental health institutions in all of our countries. And that includes occupied territories and specifically the West Bank. So I would ask you to start to really take a stand for that if you're interested in Muslim mental health. The other piece is it really helps us to sort of imagine what COVID looks like under occupation, but also what research looks like under occupation. And I want to give you just a tiny story. So about 4 or 5 years ago, we were working on a program that had nothing to do with occupation. We were working on a parenting program for children with autism. And we needed a curriculum called Incredible Years, an amazing curriculum for families with children with autism spectrum disorder. We ordered it, and in 6 weeks, it got to the other side. So what we call the 48 lands, the part of Palestine that were taken in 1948. For a year and a half, for 18 months, a box with curriculum and a frog puppet sat under occupation, and we could not get that curriculum. We could not begin to utilize that curriculum. We could not begin to interpret that curriculum for 18 months. After arguing and fighting and following and paying a fine that was worth 3 times what the curriculum was worth, we were able to liberate the frog. We put him in a kofia. We marched around with him. But I want you to imagine, what do I tell my funders who paid for this grant to be able to do this curriculum with parents about a 1.5 year delay? What do I tell parents who desperately need this service? And by the way, if we use the word occupation in our research, we are told that we are being political. We are told that this is no longer science. So I want you to imagine really the resistance and the persistence in doing science, in doing mental health education, in doing psychological education under occupation. So everything that you hear from our students, from my colleagues, please know that each of these presentations is a labor of love, really and truly. So with that background, I'm going to talk a little bit about this work with the fear of COVID-19 scale within a Palestinian context. And let me see if there we go. So, as you all know, and this is, I know, not the first, second, third, fourth, fifth, or sixth presentation about COVID. In March of 2020, there was a new phenomenon to the psychological world, which was described as the COVID-19 pandemic. Fear was obviously enhanced by the particular characteristics of COVID-19 itself, which included the high level of transmissibility, the severe health outcomes. It led to death. The invisibility, it wasn't something you could see. It wasn't leprosy. You didn't know who to stay away from or who to get close to. The unfamiliarity, this was something really that had not been seen in the world before. The social impact, especially for those of us from traditional communities, where when we are in under pressure, the idea is to come together. And we were told that coming together itself was dangerous. The globality, it was something that affected the entire world. And then the fluctuation of information, right? So the fact that we got different information every single day, we were getting daily directives from health professionals that were changing, that were variable. Now, on top of that, I want you to imagine sort of setting the scene of what that looked like in the occupied territories. So in the very beginning, from March till about May, the occupied territories did not have, and I want you to remember that this is a place that does not have power over its own borders. It did not have the ability to bring in vaccination, testing, ventilators. At the time of when the pandemic started, we had, the data fluctuates between 5 to 15 ventilators in the entire West Bank. So we had no ability to manage that. And by the way, not only the remedy was coming from the occupying forces, but the disease itself, because Palestine is so closed off. In the beginning, we did not have cases. The place that cases were in the occupied lands. Unfortunately, we also have folks who have no choice but to work within those occupied territories. So that we knew that folks were getting the illness from the occupier, but we had no ability to close it off. So what the declared state of Israel did, what the 48 lands did during that time, was they shut off for their own protection. So the workers that were on that side stayed on that side, but then we had a social phenomenon called Ramadan and Eid in May of that year, if you remember. And then we had, of course, this very difficult struggle of people wanting to come home, wanting to be with their families for the holiday, but knowing they were coming home with a risk. And again, a risk that was coming from an occupier, and who, if you remember during this time until the day, the declared state of Israel had this amazing program where they've had 4 vaccinations for everyone within the country. They had multiple testing, but those resources were not trickling over to the West Bank. So we had high risk coming from a foreign occupier, and we had no ability to either engage in the political or public health kinds of steps that we needed to do to really protect our population. Okay, so what were some of the fear triggers within our community? So one, of course, was news coverage. And if you remember, this was something that was happening 3-4 times a day, where we were getting bombarded with the information about and variable and quick moving information about what was this disease, what we were supposed to be doing, masking, not masking, medication, not medication, testing, even before we had vaccinations. People were also going on the internet, and as you know, the internet is a non-monitored public space. So they were getting all sorts of information about what this disease was. There was conspiracy theories. There was a huge amount of misinformation. There was community discussion. Now you have to remember that we're in an occupied territory, which means we have a pretty high level of suspicion. As we say in Palestine, everybody is their own prime minister because we don't trust anybody else. So we were having community discussions within families, within small communities, to figure out sort of on our own what we were going to believe and what was not believable. We had knowledge of infected individuals in the community, and those rumors started trickling in. So-and-so had it, so-and-so had it. We had health symptoms of self or others. If you remember, I can remember being, as a psychologist, sort of taking on that role of a medical doctor when every single one of my clients said, I cleared my throat 3 times. I'm sure I have it. And having to sort of every time you all remember, every time somebody sneezed, being like, no, this is it. We're all gonna get this horrific disease. There were COVID-19 restrictions that were invariably instituted. So our universities shut down, but families were still gathering. This is our way. The other thing was the shortages. We had no PPE. We had no masks. We had very few tests. We didn't have vaccinations. And finally, when we got vaccinations, a lot of them were expired. So there were shortages on every level of what was needed to manage this crisis within our community. There were obvious economic pressures, and I cannot tell you the horrific levels of poverty. We have a community that is already over 60% unemployed. And then when those small businesses, which is the way that most of our population makes its money, when those were closed as well, how difficult life became. And then there were employment considerations. A lot of our work cannot be done by virtually. So the idea was, what were we going to do with people? What were we going to do with physicians? I keep pushing the wrong button. So the idea was, what are the mediating factors for managing this COVID-19 fear? What did people have, right? So one is that we had individual coping skills. We had whatever we came with before the pandemic to manage stress, right? So there were some people who would go to look for information. There are some people who would pray and look for spiritual advice. There are some people who would go to their family. So we had whatever individual coping skills already existed within that person. We also had medical understanding. The one thing we have in the West Bank is a multitude of medical professionals. As we know, every Arab, every Palestinian family needs a doctor. Many of them have it. So there was a lot of intergenerational and interdisciplinary discussions about what this disease was. We also had health risk factors. So one of the things that you'll see that we looked at in the study is smoking, and the idea of folks who had respiratory diseases, folks who were smoking had a different, we knew there was, and then the aging population, that there were differential health risk factors as well. There was a personal health history, what that person's individual experience with doctors, with medical information was, with medical services was, and then there was this access or lack thereof to health resources. And when we started the pandemic, we were in clear need of health resources that just were not open to us as a population. So there were some characteristic symptoms of what COVID fear looked like. Anxiety, obviously, depression, not only because of the loss within communities, and there again were some families that lost multiple family members, but also the depression around the social isolation, the fact that folks could not travel in or out of the territories. Hypersensitivity to bodily sensations, where we would have folks really scanning their bodies on a continual basis. Is that a sore throat? Is that a headache? Do I still taste food? All of those things that were sort of red flag symptoms that we were looking for. We had either avoiding concentration on the media coverage of COVID-19, and I know I told many of my clients, turn off the TV. You cannot watch this 24 hours a day. Or we would have the excessive concentration where folks would be watching, would be trying to catch new information continually. We had looking at this as a catastrophe, really as the end of the world. There was a lot of fear that this was it. That this really was going to change the face of the world as we know it. There were thoughts of death of self or others, insomnia, which is always a problem in the occupied territories, became much more of a problem. Okay, so part of what we looked at very specifically were what was it about the COVID-19 experience that was particular to Palestine? One, of course, was the limited confidence in medical information. A lot of our medical information was coming from the occupying forces. Again, you're not going to believe the people who are occupying you when they tell you what to do. There's also a continual lack of confidence in medical professionals because of the particular circumstances of occupation. There was an uncoordinated societal response at every level. There was not a sort of a one voice speaking. There were many voices speaking. Many times they were speaking in conflict, and that was true across the world, but very specifically to Palestine as well. There was no lead expert communication. So while in the US we had Dr. Fauci, who even if we didn't like anything else going on, we sort of had that voice of reason within Palestine, within the West Bank, we did not have that sort of concentrated one expert of communication. There was limited medical resources. We just did not have the materials, ventilators, tests, vaccinations when we needed them. There were borders. So we were not able to close our borders. We were not able to control our borders. We were not able to tell folks from the 48 lands that they could not come in or they could not send people back. At the same time, we had citizens who wanted to come back. We had over 30,000 individuals working in the 48 lands, the declared state of Israel, who were getting exposed to the disease. And like I said, during Ramadan, during Eid, during their regular times off, who wanted to come back to their particular communities. We had this sort of comparison of the health system. So not only did we not have those resources, but all we had to do was to turn our heads and we could see a declared state who was taking extra care and had more than enough of those resources. And that was particularly painful. We had of course, the delay of vaccination. And then when we had the vaccinations, they were not the vaccinations that were the most indicated. We also had the denial of treatment from the 48 lands, where people who were really desperately ill were not able to get services. And then we had this feeling of international abandonment because each of the international countries were kind of taking care of themselves. So one of the things that we worked on was this idea of fear of COVID-19 itself. This was the fear of COVID-19 scale was created in 2020 in Iran to examine the fear of COVID-19 and how it affected compliance to public health mandates, immunology, and recovery. This was validated across the Arab-speaking world, but it had not been validated in a Palestinian context with the unique factors that we were exhibiting. So our participants in this study were recruited online and again, this was during COVID, so there was no face-to-face contact. The entire study was done digitally. We had a total of 644 recruitees, people who were participants. 216 of those were male, 448 of those were female. The ages were 19 to 43, with the mean being about 33, 34 years of age. About 88% of those in the study had college degrees, and that actually was because it was recruited online. Those are folks who have the most contact with sort of the internet. And then 12% were smokers. Again, we had smoking as a risk factor because of the respiratory nature of the disease. What we did was to look at this fear of COVID-19 scale and compare it to what's called the health anxiety scale, which was an already validated measure within our communities that looked at general fear of exposure and contamination. The fear of COVID-19 is a self-report, a 5-point Likert scale with a score range of 0 to 35. Higher scores are more indicative of higher fear. So what were the results? What we found is that COVID-19 fear was indicated by a single factor related to but distinguished from general health anxiety. So the fear of COVID-19 was in fact its own unique characteristic and was distinguishable from a general health anxiety. Within our sample, females demonstrated a higher level of fears than men, and that was at 0.001 significance. Lower educational attainment was related to higher levels of fear, also significant at a 0.001 level of significance. So that was folks, females were more fearful, folks with less education were more fearful, and then smokers were somewhat more fearful at a 0.04 level of significance. Fear of COVID-19 is an actual condition that affects the individual's well-being and has long-term consequences on compliance with public health mandates, ability to withstand social restrictions, immunology, and recovery if infected. So we need to begin to look at this fear of the disease as apart from the disease, and how the fear of disease gets in the way of people complying with the regulations that are put in, how it can cause depression and anxiety that lowers immunology, and really affects well-being going forward. Fear of COVID-19 was directly related in our study to social realities such as occupation, which affect the lived experience of both fear and infirmity. Cognitive behavioral interventions need to be innovated and applied to the fear of COVID-19 phenomenon as in its specific and unique community. So we need not to be able to say the experience of folks is very different depending on where they are. As somebody said, we are all in the same storm, but some of us are in houses and some of us are in tents and some of us are out in the open. So we really look, and our actual lived experience is very different. So I thank you so much for your patience and your interest. And if you have any questions or interest in our study, it is in the process of being published, and we will let you know when that happens, inshallah. Thank you.
Thank you so much, Dr. Berte. Thank you for that, Dr. Berte. And if you have questions, please put them in the chat and we'll get to them, or even comments, anything positive. Assalamu alaikum, and we're back. Again, this is track B, and we're moving on to our next presenter, Dr. Adnan Hammad. He is the president and CEO at Global Health Research Management and Solutions in Detroit, Michigan. Dr. Hammad is an adjunct professor in the Department of Family Medicine and Public Health Sciences at Wayne State School of Medicine, and is also an adjunct professor for the School of Medicine and School of Public Health at Michigan State University. His presentation is titled Global Health in the MENA region, amidst pandemic environment, Perspectives, Challenges, and Opportunities. Please welcome Dr. Adnan.
So this is.
Yeah, you can move it. Thank you.
I want to thank the organizing committee for conducting this important forum on mental health and Muslim perspectives. My name is Adnan Hammad, and I am the president of Global Health Research Management and Solutions. Today, I want to talk to you about recognizing ways in which global health can affect the health behavior of individuals and the broader community, and introduce strategic solutions for health equity and social justice. And hopefully we can conclude this presentation by reviewing the burden of health emergencies as a result of the continuous displacement in the MENA region. I must say that COVID-19 during the last couple of years has taught us some good questions. Among these good questions is the fact that the global public health arena, or the global public health system worldwide, has actually failed to accommodate the public health crises and the public health mitigation interventions in a global perspective. How do we define a global health? Global health is an area of research and study and practice that places a priority in improving health and achieving equity for all people worldwide. The change in terminology from international health to global health, as a matter of fact, reflects the process of globalization of public health arena. Improving health is one important aspect. While health is often thought in a physical or healthcare context, its meaning is much broader. As the WHO defines it, health refers not only to absence of illness or disease, but also as defined in the 1946 Constitution of the World Health Organization. It is a state of complete physical, mental, and social well-being, as has been declared by the WHO. Achieving equity is a very important aspect. When I say equity, we have to achieve equity, not equality. Everyone should have the opportunity to live life that supports good health. Reaching beyond border, global health deals with health issues and determinants that are transitional, meaning that they affect multiple countries. And this is really the merit about the global health. It does not really affect just us here in the United States, but it affects other people in other parts of the world. As we have learned from COVID, experiences, we also learned that everybody can be safe when everybody is safe. So we cannot just be safe in the US, but not in Bangladesh, and Indians cannot be safe if Britain is not safe. Uniting disciplines, global health issues involve complex interplay of factors, many of which exist beyond the confines of a clinic. They must be approached from multiple angles: cultural, economic, environmental, infrastructural, political, social, and technological. This is really the uniting disciplines of global public health. It is not just the healthcare system, it's not just the public health system, but it is really beyond that. It is the social determinants of health. Building partnerships is very important. No one sector or organization can achieve global health solutions on its own. The complexity of the problem require alliances that bring together different perspectives, organizations, and skills. The global health partnerships were successful to address the considerable burdens of communicable diseases and typically neglected diseases in low and middle income countries, but in the same token, with non-communicable diseases now accounting for more than half of the burden of diseases, we need to pay attention for both communicable and non-communicable diseases. I want to move a little bit to the MENA region. The MENA region, the history, vital statistics, emergencies, epidemiology, and trends and challenges, and the way forward. MENA region, as we all know, it stands for, or the EMRO region, it stands for the East Mediterranean region, including the MENA, which is the Middle East and North Arab Africa region. Region spans from Pakistan in the east to Morocco in the west. This region has about 700 million people living in that region, with almost 25 countries characterized by diverse socioeconomic status, but similar cultural and history and health challenges. MENA region, which was part of the Islamic and Arab world, is spread throughout the area of Europe, Africa, and Asia in the past days. And this map, can actually tell you where this region has been and where, and it has, some golden history in both the MENA region, and it reached even Spain, and it has been characterized with a lot of development, including medicine, mathematics, algebra, and what have you, and even in music as a way to actually treat patients. Now, the current MENA region composed from 21 countries with a population of about 350 million people. Most of this region, unfortunately, has political upheavals that affect the mental health and of course the medical and health aspects of the population. This region characterized by disparities in socioeconomic and healthcare status, mental health due to upheaval of wars, and the resulting PTSD that actually account about 15% of the region suffers from PTSD. Smoking is another chronic behavioral health risk factors in that region, and lack of health-seeking behavior, either because there is no resources or because people are overwhelmed with other factors. Chronic diseases is present in this region. 32% of the region suffer from cancers and cardiovascular diseases. 25% of that region suffers from diabetes, and again, chronic respiratory diseases and other NCDs also in that region are present. Global refugee facts is one of the most characterizing aspects of this region. By mid-2021, the number of forcibly displaced people rose to 84 million, greater than the total population of the United Kingdom. 48.3% are people displaced within their own country. 68% originated from 5 countries: Syria, 7 million people; Afghanistan, 2.6 million people; Venezuela, 4.1 million people; and Sudan, 2.3 million people. 35 million people are children. EMRO region refugee facts indicates that this region countries characterized by a diverse range of socioeconomic status, political upheaval, displacement, and health challenges. As a matter of fact, more than 51% of the refugees worldwide actually live in the MENA region, and this really tells you the magnitude of this problem in the host countries who are actually having this crisis in the MENA region. One of the most disturbing facts is actually children labor. Refugee children are actually put into work, and their schooling environment is not conducive enough for children to actually attain schooling, because most of those children, who are displaced, have a schooling environment that is not really conducive for good learning. In addition to the artillery and bombing of civilian areas where children are living there as well. These are Syrian refugees, children in Southwest Syria refugee camps, where actually suffer from the cold winter and the cold weather that affects their health and well-being and schooling attainment to that in that region. Some other facts about the region: 2/3 of the countries in the region directly or indirectly affected by emergencies. By the end of 2021, out of 140 million people in need of aid globally. More than 76 million people, which constitute about 59%, live in countries in MENA region affected by emergencies. During the period of 2018 and December 2020, more than 3,000 adults and children drowned in the Mediterranean Sea trying to escape from that region to actually Europe. Graded emergencies in the region as of September 22 indicate that still we have emergencies as level 3 with Iraq and Syria and Yemen and Somalia. Selected infectious diseases outbreaks in the EMRO region between 2017 and 2018 indicate that cholera in Yemen and cholera in Somalia and MERS in other countries in Sudan and multiple measles in that region are actually present or prevalent until now. Cholera in the MENA region can be found in Yemen and Somalia and Iraq and Afghanistan and other parts that have displaced population. COVID-19 in the MENA region, governments in the MENA region reacted to contain COVID-19 by developing policies and containment measures. This was helpful during the first wave. As of January 26, 18,933,000 cases, 5.2% of the global count, with 321,411 associated deaths, 1.7 of the global death count. Most countries in the region are in the community transmission phase. Healthcare systems could not actually cope with the population trust in public institutions. Vaccine hesitancy and vaccine myths are very prevalent in the MENA region because their vaccine rate is not as effective as other Western countries. The refugee crisis impact on host countries, such as Lebanon and Jordan, Egypt, and even European countries. Host communities are affected by the impact of displaced population. Mental health disorders are common in these areas, with a growing number of people requiring life-saving intervention and the treatment of communicable and non-communicable diseases. I want to touch a little bit on human rights crisis in the MENA region and its impact on mental health and of the population. The indiscriminate artillery and airstrikes attack on certain population in the MENA region, like Yemen and Syria and sometimes in Gaza Strip, have actually left millions of civilians, children, and women severely injured, displaced, died, especially in Iraq, Syria, Yemen, and Gaza Strip. Landmines are very common in certain parts of this region, where it does affect the livelihood of children and families, especially in agricultural area where they cannot really function. Children and armed conflict is another human right violation, where some of these armed forces actually allow children or ask children to be part of that struggle. Challenges of global health partnerships. Neither global health partnerships nor global health research are removed from underlying political inequalities, competition, economic growth, and opportunity. Health equity must have a global recognition and the practice. Health equity assures all groups, irrespective of race, ethnicity, sex, and equitable access to social and environmental conditions. A group at risk for health disparities, normally they are ethnic minorities, immigrants, refugees, women, and disabled population. Social determinants of health is one of the most important solutions for these disparities in health and lack of health equity among these populations. The framework for effective collaboration in global health partnerships and global health research indicates that there must be equitable balance between local and foreign partners. There should be shared vision, and there should be equity rather than equality principles in the place. The core values of global health partnerships and global health research focuses on the need of common goal, and obviously the value core concept that is built on commitment, trust, and respect for societal norms. Communication and leadership and resolution can be reflected in underlying power imbalances and embracing inequalities between south-north of public health, private or global local collaborations. And this is an issue that we normally find when we wanted to institute a global health collaboration, that there is a vast difference between a global north and the global south. And that is an issue, that's an issue that these bridges, they have to actually come closer together for the population to actually have equitable resources and for a global health to be effective in its deliberation. Sustainability. One major concern about the global health partnerships is sustainability. In low-income countries, health systems are seriously underfunded. Improvements that have been realized cannot be sustained after a period of which funded project has been expired. Sustainability should be part of the project design when we have these proposals set for interventions. Our collective responsibility demands from us to build and to strengthen academic partnerships. It demands from us to actually promote partnerships between researchers and academics and community. We should not underscore the community. We should not really undermine the role of the community in research. And we should also encourage community participatory research, because the community needs scientists and the scientists need community. Academia needs the community and community needs academia. And it is really a partnership between both parties. We have been doing, as a global health interventions, we have been doing global health conferences in the MENA region. This is the Global Health Congress on Immigrants and Refugees that has been conducted in 2018. It was attended by 2,419 people. This conference is actually going to take place this year, May 30th and 31st on Turkey, Gaziantep, and is going to deal with COVID-19 in the MENA region, lessons learned in the research, public health policy, and the clinical practices. And I hope that some of you can join us in this very important meeting that would encourage global health partnerships and global health research among US, European, and MENA region academic and other healthcare systems. I'd like to acknowledge all the partners that have been worked with us in these global health interventions, and thank you for the opportunity to share with you the importance of global health partnerships and global health research. Thank you.
Thank you, Dr. Hammad, for the wonderful presentation. So next we have our presenter, Dr. Furqan B. Irfan. He's been presenting on the topic of Pakistan COVID-19 outbreak, preparedness and response, situational analysis.
Dr. Furqan Irfan has an MD, PhD, and an MBA. He's an assistant professor and director of research development at Michigan State University College of Osteopathic Medicine. Welcome, Dr. Furqan Irfan. And
thank you, and it's a pleasure to be here.
Thank you. And can you share your screen for the presentation, or you want me to share it?
I'll just share it. Just give me 1 second.
Yeah, we can see your screen. So it's all yours now.
Okay, great. So thanks for the introduction, and thanks for giving me a chance to come and present some of the work that we've done, and how was Pakistan's preparedness and response, and how they managed to control the COVID-19 and dealt with it at a national level. I would also like to introduce my my colleague, Dr. Noreen, who's not over here, but she was instrumental and in in this piece of work. She's the team lead of the COVID-19 response and screening program at the Ministry of Health in Pakistan, and she's also an alumni of the FELTP program at the CDC on field epidemiology. Okay, so briefly, we're going to go through the issues and challenges with the COVID-19 situation in Pakistan, the WHO strategic preparedness and response plan for COVID-19, which essentially consists of these 8 to 9 pillars of country-level coordination, risk communication and community engagement, surveillance, rapid response teams, points of entries, national labs, infection prevention and control, case management, and operations supports and logistics, and vaccination. So initially, Pakistan, shares a border with both China and Iran. China was where the whole COVID-19 outbreak started, and initially, that was the epicenter of the spread of the COVID-19 pandemic, and then Iran was another, became another epicenter down the line. And so sharing a border with both China and Iran and Afghanistan as well, with, where COVID-19 outbreak could not really be monitored or controlled, did put, Pakistan in a very interesting dynamics. There are 19 operational points of entry, including air, land, and sea routes. Pakistan, has a huge population of 221 million. And so the risk of local transmission with, crowding and high population density areas in the urban cities makes the risk of local transmission quite high. Again, Pakistan is a developing country with, low resources, weak health system. And again, as with all other places, there was a lack of awareness and myths in the general public regarding COVID-19, and then there were emergent strains as well coming out as vaccination rollout campaign was started. So we've kind of gone through this. Pakistan reported its first confirmed case on 26th February 2020, linked to travel history from Iran, and then there was a sharp surge of COVID-19 as many of the pilgrims returning from Iran were placed at quarantine facilities at the points of entries, and then it was first week of March when the COVID-19 pandemic really took off, and there was local spread. Punjab and Sindh, there are 4 provinces in Pakistan of now I think 5 provinces in Pakistan, of which Punjab and Sindh were the worst hit, with more than 115 districts involved. Let's see. So WHO has a strategic preparedness and response plan, with different pillars, and the plan was brought about to encourage all of the countries to act uniformly, to coordinate and contain the threat, and consider all the important aspects of controlling a pandemic. However, the WHO plan for countries is not really does not really address the animal to human transmission for zoonotic diseases. It really aims to stopping the chain of human to human transmission. So at a country level coordination, in coordination with the government agencies and the ministries, WHO recommends these actions. A national command center should be there with the national public health emergency plans, establish a metrics and monitoring evaluation systems, establish an incidents management team. I'm going to be skipping quite a few slides, otherwise I'll go over time. So how Pakistan went about with the country level, coordination, planning and monitoring aspect of WHO's, guidelines was they created a national action plan for COVID-19, as a blueprint to manage the entire situation in Pakistan. There was a policy framework. There was establishment of National Emergency Operations Cell in National Institutes of Health in Islamabad. And then there was establishment of an incident command and control center as well. There were advisory and alerts continuously issued to all relevant stakeholders, and there were guidelines and standard operating procedures developed for international flights inbound to Pakistan at the airports. There was a national core committee that was developed as the government lead agency for controlling the COVID-19 pandemic, which was under the direct supervision of the Prime Minister. And then there was the National Command and Operations Center, NCOC, which was a joint civilian army body that was formed to act as an implementation arm of the National Core Committee recommendations. The second pillar was the risk communication and community engagement strategy. And so this was critically important because there, COVID-19 was a new disease. There were lots of perceptions and disinformation about COVID-19. Also, one of the things was to convey to the community and the public at large about the non-pharmaceutical interventions like masking, social distancing, lockdowns, etc. And so what Pakistan did was they launched a national health helpline. There was launch of an online platform for awareness of the COVID-19 disease. They adopted the WHO's risk communication and community engagement strategy. There was establishment of text messaging and calls by Pakistan Telecommunication Authority. And there was dissemination of educational materials guided by risk communication strategy for public awareness through all forms of media, print, social, and electronic. They also created an interactive cell phone application that was launched to provide information to the public regarding COVID-19 by the National Information Technology Board. The third pillar is regarding surveillance, rapid response teams, and case investigation. And again, this is a public health intervention that is, to rapidly detect any new cases, contact trace them, identify the cases, monitor the COVID-19 transmission, and then report it back to the WHO within 24 hours. And train rapid response teams to do all of the surveillance, investigate the cases, conduct contact tracing within 24 hours, and then generation of these weekly epidemiology and social science reports nationally. So Pakistan adopted the strategy for test, trace, and quarantine. The test, trace, and quarantine strategy objectives were to identify, new disease clusters and hotspots, and to enable the strategy of targeted lockdowns that the government introduced. And part of this was to avoid national level lockdowns that had been employed by many countries globally. And trying to avoid a national lockdown was partly because Pakistan has a lot of the population that lives at or below the poverty line with daily wage earners. And so implementing a national level lockdown would push many people into poverty, and they would face issues of acute hunger and mass unemployment. So to avoid national level lockdowns, the country instituted a policy of targeting lockdowns that were guided by the test, trace, and quarantine strategy. And this plan was chalked out and coordinated between the federal and the provincial governments. And they also called it smart lockdowns that were to be based on this tracking, tracing, and screening strategy. And all of this comes under the disease surveillance system by the WHO. There was also disease surveillance and response unit teams that were strengthened at both the district level, and all of this was coordinated with the emergency operations centers at the provincial level. Points of entry is next. Points of entries are important not only for surveillance and risk communication, but also to control the importation of the virus from outside the country. And so Pakistan has 31 points of entries across all seaports, land crossings, and airports. The National Action Plan issued, standard operating procedures and guidelines for at all points of entries, which were different for airports, seaports, and land crossings. Thermal screening was employed, and active case finding were done at 8 international airports and Karachi seaport. The borders with Iran, Afghanistan, China, and India were closed. There was closure of borders. And again, they used like thermal scanners at airports to check for fever among travelers. At the time, there had been 22,583 flights and 3.7 million passengers that had been screened at these points of entries with data retrieval through health declaration forms. The contingency plans and SOPs, were strictly followed. There were trained rapid response teams with an ambulance that were made available 24/7 for shifting of suspected cases from these points of entries to designated hospitals at district levels across the country. There was a mass program of training of human resource on doing all of this. And digitalization of these point of entries was underway at the time. Now it's complete. Next is the national labs. At the start, the country needed access to international COVID-19 reference lab, and later they established their own national COVID-19 reference lab. Also, they had to establish and make sure that all of the labs in the country received and followed the standard operating procedures for, specimen collection, management, and transportation of COVID-19 diagnostic testing kits. And so all of these systems, establishing, standardized systems for molecular PCR testing for the COVID-19 and access to reagent kits was done. Sharing of the viral genome sequencing data according to established protocols, firstly within to the national reference lab within the country, but then from there to the WHO, and all of these linkages to data with epidemiology data for like timely report and analysis. And then they developed search plans. They were monitoring and evaluating the diagnostics and testing mechanisms, data quality, and establishing quality assurance systems from point of care testing to actual reporting. The testing capacity of Pakistan was about 20,000 tests per day at the time, which was in May. From then on, the capacity has increased greatly. Again, from May to June, the testing capacity increased from 20,000 tests per day to 32,000 daily tests. And then further on, the testing capacity increased to 61,000 tests per day. This was more, I think, of September, with 80% utilization. And Pakistan was performing at the time 183 tests per million population, with a test positivity here that rose to 9% at the start of the third wave. This was in 2021, March 2021. These are all test positivity, percentages as of 19th March 2021 among different areas and provinces in Pakistan. You could see they ranged from 2.8% in Sindh and 0% in Baltistan to like 12.2% to 12.5% and 13.4% in Punjab. Infection prevention and control was another pillar of the WHO recommendations, and IPC, infection prevention and control, were assessed at all levels of the healthcare system, staff training with sufficient personal protective equipment and wash services, hand hygiene stations were established. And all of this was assessed not only in the hospitals and the health system, but also in public places. There was a national infection prevention control guidance plan, and all of this was monitored. Enough PPE supply was ensured for all the hospitals, and early on this was there was a huge shortage of this, and then gradually they ramped up the production of PPEs internally. And then they also implemented triage, early detection, infectious source control, visual alerts, and all of this was developed into educational material in local languages like Sindhi, Baluchi, Punjabi, etc. For disseminating it to the community and population. Oh, I see that. Dedicated quarantine places were ensured at all levels, and staff were trained. These were especially more important for Pakistani citizens traveling back from to Pakistan from especially countries in the Middle East. And a strict implementation of all of the SOPs was ensured. Case management again was triage and screening areas at all healthcare facilities, and ambulances were made available for transfer of patient. Isolation wards were established, emergency response teams, and so on and forth. Ventilators were made available for COVID-19 patients. And we are nearing the end with operational support and logistics, a central stock reserve for COVID-19 case management and for all the PPEs, and this was done. These were some of the initiatives by the National Command and Operations Center. There was a Prime Minister's Relief Fund, SAS program, and all of these were this was the app. All right, I will. This was a snapshot of how the COVID-19 situation played out nationally. These were the tests that were being performed in blue. Active cases were in red, and this was how it all played out. All right, I will just talk a little bit about vaccination. In Pakistan, there were 3 vaccinations: Sinopharm, AstraZeneca. This was the Oxford AstraZeneca vaccine, and the Russian Sputnik vaccines that were made available to the public. Pfizer vaccine also was introduced, but it wasn't in a huge supply. These were the main vaccines. All right, I will stop here and see if there are any questions. I know I didn't want to go over time.
Thank you so much, Dr. Irfan.
All right, thanks. Happy to present my work. Happy to be here. Are
Before
all of
we
you at
start
Yale
the-
right now?
Huh?
Are all
Yes,
of you?
we
is
are
this
at
Yale?
Yale. Yes. We are at Yale. It's a hybrid conference, our
Okay.
first hybrid conference. So we have a lot of people tuning in, and then a lot of people in the conference. And we have different tracks, and so they're in different
Sure.
different rooms, different buildings.
Sure.
So it's a good
Well,
experience.
thanks.
So any of you who couldn't make it this year, inshallah next year you can.
Hopefully, I think next year it's going to be at Michigan State.
Michigan
So
State, yay!
yeah. So
Inshallah.
so all of you come here then.
Yeah. So before we get to the questions and answers, we do have one question for each speaker. Let's put the CME credit slide up. For those of you who are asking about the continuing medical education event code, we're going to put that slide up for you right now.
Sure.
Thank you again for all of our speakers. We had a question for Dr. Berte, but I think she had to run. So Dr. Hammad, we have a question for you.
Dr. Hammad?
We have a question for you. We have a question for you.
Question?
Yeah, no, you can stay there. Yep. So the question is, you talked about global health research with international collaborative efforts. Can you tell us what that looks like? Do you mean like a diverse team of researchers, cross-funding, like funding from here and there, or like comparative research where there's a demographic that studied like adolescent here versus adolescent there in the city? Like, how would you describe what global health research looks like? You can.
Thank you so much. Global health research is evident, and it has been a practice for so many years. But COVID-19 is really one of the positives of COVID-19 during the last couple of years is giving an opportunity for researchers and scientists to collaborate in research and establish more research partnerships. And obviously, NIH funding has been widely open for research collaborations between Western countries and other countries. NIH Faculty Center has been widely open to actually give grants to different parts of the world. This actually opened an opportunity for the Global South and the Global North to work together. Most of these research interventions have been taking place in academia. But again, these academic centers also been working with community-based human and service organizations who were in the field doing COVID-19 public health mitigation practices, etc. So we need more of that. This has been evident. It is increasing. These collaborations and research collaborations and interventions have been increasing in the last couple of years. I anticipate that these collaborations will be also on the hike of doing more research in the next 5 years, and I just hope that these developments will actually teach us a lesson to keep doing these global health partnerships in research in relation to COVID and other communicable and non-communicable diseases. And thank you.
Thank you. And for Dr. Furqan, Dr. Irfan, so on one of your slides, you mentioned that there was rapid response teams were deployed. So I was just wondering, so were the rapid response teams, were they mostly deployed to large cities in Pakistan and or rural areas? And what was the difference in the rural versus city community reception of government aid?
Yeah, I think that's a very important question, and the latter part of it, relates to equity. The rapid response teams were established at district levels, and again, I mean, it depended. Districts in larger cities and densely populated areas had more rapid response teams than districts in rural areas, and and that was done mostly at a provincial level. That was coordinated by the National Command and Control Center, based at the federal government level. Regarding, could you repeat the second part?
What was the difference in reception of the community to the government aid for COVID? Like, were people like, oh yeah, COVID exists and we want your help? Or are they saying like, I need to focus on food for tomorrow for my family?
Yeah, that's a good question. That's a really good question. We unfortunately did not study the community response as part of this project. However, we've got another study. In fact, I was just revising the manuscript for resubmission to the journal. It's been accepted at the Journal of Global Health, and again, I mean, we looked at the trade-off between public health policies versus the economy in the pandemic, and we took the SARC region. We studied the SARC region, which includes India, Pakistan, Bangladesh, Sri Lanka, Maldives, Bhutan, Nepal, 7 countries, also Afghanistan. These 7 countries make up the SARC region in South Asia. So we looked if we looked at the health policies and all the epidemiology, health system indicators, and then we also looked at the economy of these countries to see if there was a trade-off. That does indirectly answers your question, although we did not directly do a survey from the community.
Right.
But yes, in that study, we did see that there was a trade-off, and most of the governments, after instituting national level lockdowns, which by the way, Pakistan did not do, but other countries within the SARC region did have national level lockdowns, which they had to eventually lift and ease the restrictions in spite of increasing cases, because of exactly what you mentioned about acute hunger, mass unemployment, putting food on the table. So it was a very delicate act of balancing losing lives from hunger versus losing lives from the pandemic.
Right.
And this was very acute in the developing countries, which did not have, generous cash programs, etc.
Exactly. Thank you so much for that.
Sure.
I mean, all the presentations today, I personally am interested in global health research, and I can see the similarities, like the region that you're doing your research in terms of policy and the kind of like the beginning part of getting aid, COVID aid to the people, and then Dr. Hammad's research of the MENA area and how the aid is being distributed and accepted there. And then Dr. Berte's research on the Palestinian area and how like they have triggers. It's all interconnected, and that's like what global health research is, and that's what we're doing. So I'm glad we're able to collaborate and share each other's research and ideas. Thank you all very much for today's presentations.
Thank you, everyone.
Thank you. Pleasure to be here.
Thank you. Assalamu alaikum.
Walaikum assalam. Bye.
Bye.